Hey, hi Ryan, welcome. Glad to have you join here, HealthTech with Purpose podcast. How are you today?
Good. How are you?
Yes, doing fantastic as well, especially learning so much from all the different health tech founders and the way you guys are changing the world with one technology at a time. So glad. I think, Ryan, why not we get started right away with a bit of your background and profile and what led you to building Vori Health? Would you like to start there?
Sure. My background, spine neurosurgeon by training, spent some time at Yale University and Geisinger Medical Center. Um, Prior to that, founded some companies, one's in the staffing space, but really true passion lies in direct patient care, and left my practice during the pandemic to try to solve musculoskeletal orthopedic conditions, starting with back, neck, hip, knee, hand, foot, shoulder, because low back pain, as an example, still is the number one cause of years lived with disability across the planet, even post-pandemic. So men, women, World Health Organization, Lancet, Economist, this has been documented ad nauseum that low back pain still is number one for what people live in terms of their life with disability. And unfortunately, most people get the wrong care, even in 2023. Depending on what literature you want to cite, up to 50%, some people think more, of back surgeries, and at least in the Western world where we have data, are inappropriate or unnecessary. 25% of the knee surgeries are inappropriate or unnecessary, according to the data, and about 15% of hips. So what that really means is we do a really good job as a healthcare society doing inappropriate care, and the inappropriate care, which tends to be procedures, is high cost. So the status quo is high cost, low value care. And the thesis of Vori being the care model's broken. So we wanted to start over. So for example, primary care providers, not well trained in back, neck, hip, knee, hand, foot, shoulder. It's not their specialty. Up to a 40% misdiagnosis rate. On the opposite side, the first physician specialist tends to be, quote, ortho. They almost are always surgeons. So spine surgeons like myself or joint surgeons, we're not well trained in non-operative conservative care. And I will be the first to admit I should not be triaging back neck patients. I'm actually the wrong provider to do that. If you have a surgical issue, great. And so the analogy would be, if you sent all patients who had chest pain to a heart surgeon first pass, you'll see more procedures. And some of the literature would suggest that up to, if you see a orthopedic or spine surgeon like myself first, 7 times more likely to get surgery, not because we're bad people, that's just what we know. And so who's the corollary to the cardiologist? Like if you had chest pain, you would go see a cardiologist as a specialist. You want to go right to the surgeon. But in the orthopedic and musculoskeletal world, you go right to the surgeon for the first physician. And so physical medicine rehabilitation, non-operative sports medicine is the non-operative musculoskeletal orthopedic expert, the corollary to that cardiologist. But that's still not enough. You still need to have those physicians actually work hand in hand with physical therapists, coach navigators, and other professions. And what you still see in the traditional world is the chance that a physician and a physical therapist or physiotherapist overseas work together is close to zero. So even if you co-locate them, they tend not to work together because the profession has been a silo. And so that is the thesis. Right providers working truly in care teams, actually doing care together, practicing evidence-based medicine, and then putting the patient first. And what we mean by that is medicine still is paternalistic. We still tell the patients what to do. You need to get this, sir. You need to get an MRI. You need to do that. And then if the patient doesn't follow the physician plan, we blame the patient as a society. The patient's non-adherent, non-compliant with what? The physician's plan? That's paternalism. That's how people talk. What's the adherence rate? What's the compliance rate? That is paternalism by definition. That's how you talk to kids when they don't clean their room. Oh, you were non-compliant, non-adherent. Versus, what's Nancy's obstacles to care? Her car broke down, her internet's down, she can't do a video visit, she lost her job, her kid's sick. No one asked. Nancy's just non-compliant in the real world. Versus taking a time to understand an individual's obstacles, what motivates them, how they experience the world, what gives them fear, and then wrap evidence-based care around them to reach their goals. You can get people quite a bit better than the traditional world if you just practice differently.
Okay, makes a lot of sense. But how do you change the whole ecosystem? Because eventually, within the system, it would be the same people who have been accustomed to, probably a certain way, which you just mentioned. So how do you bring that intervention, if you'd like to elaborate on that a bit?
You have to start over and build from scratch. And so I don't think you can change the system at large. I think you have to build from scratch and grow, and then more pressures. So you see these good use cases of, for example, in the primary care world, at least in the United States, you have groups like One Medical Senior, previously known as Iora Health, and the value-based care primary care. Start over, build from scratch. Oak Street Health, which just got acquired by CVS. Value-based, primary care, let's practice medicine differently, patient-centric, start over, build from scratch. You have others in the women's health space like Tia or Kindbody. We want to practice differently, start over, build from scratch. In the kidney space, you have Strive Health and Monogram Health. We want to practice differently, start over, build from scratch. In the GI space, people like Oshi Health or Vivante Health. Okay, let's start over and build from scratch. And so you see a phenomenon moving along of, if the thesis is the care model's broken, you see groups starting over and building provider organizations from scratch that practice differently. If your thesis is just an access problem where the patients just need more access, then you can do 1099, which is temp worker models, and just give people access to the current care model. But if you want to actually change care, in our opinion, all the way, then you start over, you employ those providers yourself, and you build a provider or practices differently from scratch from day one.
Okay, makes sense. So, tell us more, Ryan, like how Vori Health is different from other virtual healthcare providers, and the unique benefits that the patient gets from this integrated approach.
Yeah, absolutely. So on that first visit, so let's say Nancy comes in with 10 out of 10 back pain, worst back pain. On that, she'll do a quick intake. She will see that physical medicine physician. So that's the board certified, non-operative, conservative physician expert. She will also see a doctor of physical therapy, and she also will see a health coach navigator, all in that first visit, who's truly a care team. We do something what's called a red flag screen. What's that? How are we sure Nancy doesn't have cancer? Did she break a bone? Is she going paralyzed? Those are rare, but making sure that there's nothing dangerous that would quickly escalate care to an image. And once in a while, someone should go right to the surgeon. Those are rare, but most people don't need to do that. So you roll that stuff out. We can order labs if it makes sense. Most people don't need labs. We can write non-narcotic, non-opiate, evidence-based prescriptions. We don't push pills on people. Under 15% of our folks will end up with an evidence-based medication that we will wean off before they finish care with us. Then it switches into a motivational interview. No one goes to the doctor for fun. People go for cancer screening. They hurt. What's on Nancy's mind? Sure, her back hurts. There's more to that. And you find that the thing that's really on Nancy's mind and what gives her the most joy during the week is walking her son to school. That's what she looks forward to, but she feels she can't because her back hurts. Her care plan will literally be walking Tommy to school. We can build an evidence-based care plan around that, as described, write prescriptions if necessary, make a medical diagnosis, order an image if it makes sense. Most people don't need imaging. Then the next part moves into what's on Nancy's mind that keeps her up at night. What's her fear? She's worried she's going to be in a wheelchair like her grandfather, and that's what she thinks about. And then she worries she'll never take care of Tommy again.
Mhm.
If you don't remove people's fear, their pain is more intense. And actually, if they have significant fear, called fear or pain catastrophizing, oh my God, I'm going to be in a wheelchair. My life is so much going to change. True or not, if someone's fantasizing about those types of things, very high chance the individual will convert to chronic pain and the brain will rewire. And so the prevailing theory in 2023 of chronic pain is actually an overactive nervous system where the brain has actually rewired based on fear, experience, or a continuous pain signal that it got to it. So we make sure that we incorporate that holistic view of what's important to the individual. It's walking with Tommy, making sure there's nothing dangerous. We can practice traditional evidence-based medicine, true care team, remove her fear. We can pull in a registered dietitian or a nutritionist if there's a nutritional component. And the whole plan will be walking to school with Tommy and getting the pain to go down. In terms of these types of results, we'll see 62% decrease in anxiety, depression. We'll see 83% of folks will get improvement in their pain. We'll see 70% improvement in global health as measured by Promise 10, which is a mental and physical holistic type of patient report outcome. Our surgical referral rate is only 2.8%. And the net promoter score ranges from 82 to 88. So overall, people like it. People are getting better. We've driven surgery down quite a bit. Our surgical referral rate's not zero. It's 2.8%. It's just low. And so we also navigate people to surgeons that make sense. But that's what we're trying to do is practice medicine appropriately, put the patient first. People have all the care providers they need. They don't have to go find them. It can be a mixture of virtual care or in-person care. 97% of folks will get better. And if they don't get to where they want, we can care navigate them to an image, escalate to a surgeon, and then help them get ready pre-operative and post-operatively as well. So one-stop shop.
Okay, great. So, Vori Health, is it integrated with the current care, like hospitals, etc., or does it work independent?
Independent. If someone needs surgery, we can refer somebody into a hospital system for surgery. We do work with some health systems, but going back to the original thesis, the average hospital system does 50% inappropriate back surgery. Practicing appropriately drives that unnecessary surgery down. Hospitals make most of their money on the inappropriate surgery. The health systems are a classic innovator's dilemma for those who've read those types of books. So in the United States, the average health system makes money on imaging, cancer, and facility fees from procedures. Most of the other medicine tends to be a loss, just practicing non-procedural medicine. COVID is a great example of that. All elective surgery was put on pause for the most part during COVID, the pandemic. Hospital was full. Hospitals were at 110%, 120%, 130%. You saw hospitals in New York City building makeshift hospitals in the parking lot, and they lost money. Mayo Clinic reported publicly a $900 million loss. Geisinger reported publicly a $300 million loss because elective surgery was paused. So the average health system, at least in the United States, is not set up to make a margin, a profit, but they're not usually nonprofits, so a margin, practicing just medicine. They're designed, their business models of the past, to make money. And most of what feeds that bottom line is facility fees from procedures. And so they are a classic innovator's dilemma that if you actually do the right thing, you bankrupt the average health system. So if they want to actually do something like this, they'd actually have to restructure. And that's a story for another day. But I would actually argue who holds us back the most in terms of care delivery advancement. It's mostly the health systems because of the way they're structured.
Okay, okay. And how do you like, because Vori Health presents an alternative which is based on the premise, just like you said, the innovator's dilemma. Um, how do you kind of balance the cost and the profits that way, like, that Vori Health still continues to operate in the good way while doing good, but by probably, of course, being a scalable, profitable business.
Yeah, one way is to be a virtual first model so that your physical location light, or so that you don't have as much dollars set up in real estate. Also moving towards value-based care models away from fee for service, where if you do a great job, there can be more upside because you're managing a population health and taking risk on a population is another way. And it's a great question. And then being disciplined to not, I call surgery, the way it's currently done, is the forbidden fruit back from Adam and Eve. And the reason it's the forbidden fruit is it's so lucrative that once you start doing inappropriate surgery, given how many dollars it feeds, it's hard to get people to get off of it.
Right.
So we built this care model from scratch, follows the evidence, patient-centric, follows the best evidence that's out there, including everything I described. Then people who don't get better, send them to awesome surgeons. Like, we're not anti-surgery, we're just anti-inappropriate surgery. And so every 100 patients that we see, about 3 of them will go on to see a surgeon. Not all of them wind up with an operation, but that's the surgical referral rate.
Right. Great. So, Ryan, what is the kind of impact Vori Health is making? Any numbers or any KPI that you'd like to share from the last years or this year?
Yeah, no, those are a great question. Some of those outcomes that I mentioned previously was in some of our data, 96% of patients showing a functional improvement, 83% of folks having an improvement in pain. On an average individual patient, you usually see about a 62% reduction in their pain from where they started. We also measure anxiety and depression as a holistic type model through PHQ-2 and GAD-2. See about a 62% decrease in anxiety, depression in the commercial population, about a 48 to 50% decrease in the Medicare population. So overall, pretty strong numbers. We also follow patient-reported outcomes such as Promise 10, which measures both global health through physical and mental health type questions. See a 70% improvement there. And we also follow things like the Net Promoter Score of how well does someone think that they would, how likely is someone to recommend your service to someone else. We live in the 80% range, 82 to 88, which is pretty strong. We would love to get it higher, so we keep working to how do you make it stickier and more fun and more engaging. And then our surgical referral rate. So in some primary care practices, you'll see an orthopedic surgical referral rate of over 37%. Ours is 2.8%. And a surgical practice, a busy one, sometimes you see the hit rate of 20%, 25%. My own clinic in the past, working at a health system, you would see 20% of folks go on to get signed up for surgery. And practicing differently with shared decision making, everything I described, evidence-based medicine, making sure people understand what their options are, get that down to 2.8. Our goal is not to make surgery zero. Surgery has its place. It just belongs at the end of the Broadway show. It's an encore. And so goal is to drive appropriate medicine, give people options, build care plans around them, what's good for them, make sure they understand what's an option versus a necessity, make sure they have fun while they do it, and get people better. And I've been pretty amazed about how well you can get people better, regardless if it's in person or virtual, if you just practice differently. And so it comes back and reinforces the thesis that the care model out there is broken.
Okay, okay, great. So, Ryan, what have been some of the challenges that you faced, while building this vision? Because I believe, of course, as a founder, you could have totally, like disassociated yourself from what's going on and towards the new paradigm. But what about the team? And then what are the challenges basically, that you faced in building this whole model?
Yeah, great
And
question. Yeah, this is a new care model at large. There's not much to compare it to. So people for the last 50 years know PT, which is physical therapy, or ortho, and that's been the referral pattern forever. An integrated care model with using different providers and practicing differently. So people are you PT? Are you ortho? We're both. We're care teams. So there's not a good comp. There's one place who's built an integrated care team from the ground up in the academic world down in Austin, University of Texas, Austin. Dell Medicine has done, but that is just in one city. But they also practice differently with great results. But you're not going to see an academic center like that scale that across the entire country, the world. It's going to stay where the academic center is located for the most part. And so one is there's an education piece of educating the market in the beginning. Difficult to get people to understand what you're doing differently because it takes time to explain it. And most people have a 6-second attention span. So first was the education of how are we different, to get those first partners to say, yes, we like this, we like what you're doing, we want to work with you. So you get those first movers. Then you can start to build on that pipeline with outcomes that you heard about. Next is a lot of the groups won't work with you until you can serve the 50 states in DC. So you have to set up infrastructure to serve all 50 states in DC if you want to go after larger clients, so now you need a medical practice, and we're not a coaching service. We are a licensed medical practice. And each of the 50 states in the District of Columbia in the United States each operate independently. So we need a separate medical representation entity in each of the 50 states and DC. So 51. License, compliance, regulation, and each state's a bit different. And you have to be able to practice medicine across state lines and follow all the rules and regulations and stay 100% compliant. So you have to set up that infrastructure. We live in a fee-for-service world to a value-based care world. We don't have one business model, which adds complexity on our back end, but that also gives us the ability to work with partners in the ways that they need. Because partners are set up in 1,000 different ways. Well, this population is Medicare Advantage, value-based care, and this population's a case rate, and this population's fee-for-service. Vori, can you do all those business models with us as well? Is also a powerful add versus now we only have one. We can help you with all the models you already have. Also gives us a leg up. And then it's on the B2B side. So we sell the health plans, self-insured employers, and then payviders, at-risk primary care providers or ACOs. Their buying time, their sales cycle is very slow. 12 months if you're lucky. Usually can be 18 months, 24 months, 36 months. They move very, very, very slow. And the sales cycle post all these banking failures in the United States. So 4 years ago was a very different time in the investment community. I got a peak. It's like the golden era. Then we went into inflation.
Right.
Then we went high inflation, increasing rates. People worried about a recession. Dollars got pulled back in. People a little bit more nervous. And then you saw Silicon Valley Bank collapse, Signature Bank collapse. You see First Republic collapse, but in essence gets bought. So 4 largest banking failures in the United States, 3 of them happened in the last 45 days, which has rattled the markets in the United States, the Asian markets, the European markets. It's caused a global ripple effect. That has also spooked buyers. So people are also buying more slowly. But that's not unique to us. That's a headwind, but also a tailwind. People want to control cost more, so they're going to want more services like us. But then also they might be more conservative in buying given what's going on in the financial markets. So, well, we're not going to implement any, we might not implement any new programs because we're just going to just watch and let the financial market settle. So it's both a headwind and a tailwind, depending on how you look at it. But that's healthcare change is not for the weary.
Okay, great, great. So, what keeps you up at night, Ryan? Like currently?
That's a great question. Mostly about how can you get this type of model to influence society faster? But fast might be 20 years. And so questions I think about is you have your standard day-to-day firefighting of the status quo does not want you to succeed, drive down surgery. It'd be great if we were not successful to some of the stakeholders. So you are always pushing that way to keep pushing. Do this for the patients.
Mm-hmm.
I do think about at night of how many people get unnecessary, how many people are on the operating room table right now getting inappropriate surgery in our most elite centers. How many people are already asleep, 8:30 a.m. Eastern right now, already asleep, about to be cut open inappropriately to feed a bottom line. That's disturbing. And how do we do what we're doing faster and faster to help curb that and really pull the human race forward over time? And so the way I think about it is, it's not really about the dollars and how much money you make. The company has to be self-sustaining and profitable, sure, to achieve its mission. But the goal is to build a company that stands the test of time long term, and that actually pulls the human race forward. That's success. Did you actually get a new care model to actually infiltrate society in a positive way, where people are getting better care, less inappropriate care, better controlled costs, and the patients have great outcomes? Because at the end of the day, we really define value-based care in our world. Value to the patient first. Did the patient get value? Did your partners, your clients get value? And then lastly, did the bottom line get value? And so much don't think about value-based care as dollars first. It's patients first, clients,
Right.
who are your customers, and then the bottom line.
Right. Okay. Okay. That's definitely a good way to operate and a good way to look at healthcare. I mean, I'm glad that we are having this conversation, because that kind of aligns pretty much with the whole purpose of Health Tech with Purpose podcast. So how you can do basically good, feel good, and be good to your patients, especially. Yes. So thank you so much, Ryan. That has been a wonderful podcast, and thank you so much for being a guest and sharing your wisdom with us today.
Thank you for having me. It's been a pleasure.